So good day everybody. We got in another case which was referred to us. That case was operated for a sinonasal mass. That means endoscopic sinus surgery was done, assuming it as polyposis. So functional endoscopic sinus surgery was done. What happened with due course, the patient after an year came to us with the complaints of nasal bleeding from that same nose. On histopathology, it was seen to be a case of inverted papilloma. So now the scenario is the patient is having a sinonasal mass which can be termed as residual. Now coming to the point when we will say it a residual and when we will say it recurrent. So if in this case, if we see the mass initially was not pre-biopsied, that means we were not knowing that we are going to operate on a case of inverted papilloma. So in those cases where pre-operative histopathology is not there we can say that the surgery was inadequate. So that means the tumor is residual. In cases where we know that we are going to operate on the inverted papilloma, and if the patient present to us with that same mass, we can say that it is a recurrent, a case of recurrence. Now, in our case, it is a case of residual. We can say that this is a residual tumor that we are going to operate. So, if we see the CT scan, that is the nose and pharyngeal non-contrast CT scan of this patient, and see the involvement that is there. So starting from the anterior most cut of the coronal, we can see here that our frontal sinus are not involved, right? So grossly we will see the CT scan. This is the nasal bone that is appearing, right? Bony nasal septum, both the side nasal bone. The frontal sinus are clear here also. The crista ethmoidalis. Now here the ethmoids have started to appear. The maxillary sinus, the right maxillary sinus, the left. And if we see in this cut, it is more clear that this site is operated. That means the right side has been operated. Here we can see some soft tissue density in the ethmoids, both the anterior ethmoids and the at the osteometal complex. So the importance of radiology is to see the extent, to see the origin. So seeing the origin of the tumor and the extent of the tumor is very important, because we are going to stage this inverted papilloma. So we all know that there is a Krause's staging for this tumor, right? And if we see the staging for it, so we all know that there are different 4 stages. Stage 1 is if the tumor is limited to the nasal cavity, right? If the tumor is limited only to the nasal cavity, not extending into any sinuses and extranasal part, then the tumor is stage 1. When we will say that it is stage 2, when it is involving the osteometal complex or the medial part of the maxillary sinus or the superior part of the maxillary sinus, then it is stage 2 of the inverted papilloma. Stage 3 is when it is involving the superior, inferior, anterior, posterior, any part of this maxillary sinus, as well as the frontal and ethmoids. Stage 4 is when this tumor is becoming extranasal, right? So if this tumor is becoming extranasal, it will be stage 4. And the important part that comes to a surgeon's mind when dealing with inverted papilloma is the chances of its recurrence. So this tumor is prone to recur, right? So that is why the determination of the tumor before operating is important, that we are going to operate on a mass like inverted papilloma. Although it is a benign sinonasal mass, but it is prone to recurrence, and it is prone to get you can say malignance. So it is associated with change or transition to squamous cell carcinoma. So these are the points that we should take while operating: the site of origin, the extent of involvement, because that will help us to determine the type or the mode or the approach of the surgery and the extent of the surgery. Now moving to this cut, as it is already an operated case, here you can see that the maxillary sinus is wide open, right? Here the anterior ethmoids, posterior ethmoids seems to be involved with this soft tissue density, that is the mass, and right now we know that this is an inverted papilloma. Again in this cut we can see that the tumor is extending into the sphenoid sinus, right sphenoid sinus. See, so this tumor is involving your right-sided the anterior posterior ethmoids as well as the sphenoid sinus. So we can say that this is a stage 3. Now coming to the management, right? So with the advances of the technology and the skills, endoscopic removal in toto is possible. So if the surgeon is skilled enough, confident enough, we can plan different endoscopic approaches like modified Denker's, medial maxillectomy endoscopically. And if it is needed, like in T3 lesions, you can combine, or we can combine the procedures like the endoscopic approach as well as Caldwell-Luck and any other. The main aim is to remove the tumor extensively or in toto, and if possible drill the bones so that these tumor do not remain and we don't get recurrence or residual of the tumor. So in this case we are planning an endoscopic approach. We'll try to remove this. We'll do the radical ethmoidectomy. By radical ethmoidectomy, what we mean is, already here the middle turbinate is not seen, so it has been removed by the previous surgeon. So radical ethmoidectomy means removal of all the ethmoid cells, the bones that are there, the middle turbinate, and curating the part. And if possible, if the nasal neuro drill is there, we can drill the bones with the light hand so that there is no residual, right? So very important to see the site of origin, the extent of the tumor, and plan the surgery, right? So planning for these tumors is important because they are prone to recur and chances of malignancy are there.